But in the elderly, we give, I think, 2 to 3 milligrams. Then also in patients with asthma, because the drug causes respiratory system depression, and they already like have issues with their respiratory system. So, yeah, you have to take good history also for what's the thing, like in children, foreign bodies in the airway. Then what else? Epiglottitis, those things, like the diseases in children, because I think epiglottitis is more common in children, right? Those diseases like that can affect the air. How come it's not shifting? So now we are going to another drug, ketamine. Like that in his notes, he only gave us like one example of barbiturates. That's all. Sodium thiopental. So now we are going to ketamine. Ketamine is not a barbiturate. Ketamine is like we saw in his, like initially he told us that it's a long acting drug. So for ketamine, it is a phencyclidine derivative. Phencyclidine is also an anesthetic drug, but like mostly used in animals. So did he? I think he said slow acting. I think it's the same. So phencyclidine derivative, it causes dissociative anesthesia, and I think he explained it. So like this is a state in which like the patient seems like they're conscious but they're unconscious. And like it doesn't cause generalized CNS depression. So it is it has potent analgesic effects, and we all know what analgesia means. It provides an amnesia in that the patient doesn't remember what happened during like the surgery. So the solution is 3.5 to 5.5 pH and a pKa of 7.5. I think we all know what the implication of that is. They explained. So mechanism of action, it acts on the NAMDA receptor, N-methyl D-aspartate receptor. It is an antagonist of that receptor. So I tried to find out what that receptor does. The NAMDA receptor is an ionotropic receptor that allows the transfer of electrical signals. And by the other hand, the sodium thiopental, it allows like signals that not signals. It allows for the transfer of chloride ions. That's how it acts. Chloride ion transfer. But this one, it is transfer of signals. You get the difference? Like for the NAMDA receptor, it allows transfer of signals between neurons in the brain and the spinal column. For this to happen, the receptor must be open. Hence, you're supposed to have glutamate and glycine binding on that receptor, the NAMDA receptor. But when ketamine binds on that receptor, and it competitively inhibits that receptor, and that's how it acts as an antagonist to that receptor. We've understood, because like this NAMDA receptor has antagonists which act in different ways. You have the competitive, non-competitive inhibitors. You get it. But ketamine is a non-competitive inhibitor of the NAMDA receptor. You get it. You've understood it. So it doesn't bind on the active site where glycine and glutamate are supposed to bind. It acts on another, it binds on another receptor site. I don't know if I've tried to explain. You remember when we had non-competitive and competitive? inhibitors. The competitive inhibitors had to be the same shape and size as the agent they're trying to inhibit. That means they bind on that exact site where that molecule is supposed to bind, right? So that's like if ketamine was a competitive, yeah, it would be the same shape and size as glutamate or glycine. So it would bind on those sites and inhibit that way. But for it, like it's a non-competitive. Therefore, it doesn't have the same shape or size as glutamate and glycine, but it also binds on the non-active site of that NAMDA receptor. You've understood? Like it binds somewhere else, but it will inhibit. So when it binds on that other site, it changes the shape of the NAMDA receptor. I don't know if you understood, like biology days. Yeah. So it binds and alters the shape so glutamate and glycine can't come and bind. And that's how it carries out its antagonistic effects. And remember, glutamate and glycine are excitatory molecules. So, like if they're not binding, that means you have inhibition. You get? Yeah. I don't know if you guys have understood. But basic concepts, that's it. Like when it binds, glutamate and glycine will not bind. Glutamate and glycine are excitatory neurons. GABA is an inhibitory one. You get? So if glutamate and glycine don't bind, there will be no excitation of neurons. That is it. That's how ketamine acts. That's its mechanism of action. It acts by antagonizing the N-methyl D-aspartate receptor. So we're saying it has a rapid absorption and distribution to the blood vessel-rich groups. Elimination is by hepatic metabolism and renal excretion. Then we'll go to the CNS effects of ketamine. So it induces anesthesia within 30 to 60 seconds. The IV dose is 2 to 3 milligrams per kg and lasts. Network is off. No, it's still on. And lasts 10 to 15 minutes. So then the IM dose, I don't know why it gave us the IM dose, but because we are talking about IV drugs. So, but the IM dose is 5 to 10 milligrams per kg and it will last 15 to 30 minutes. So it will last longer. Then it also causes potent somatic analgesia at subanesthetic dosages of 0.1 to 0.5 milligrams per kg. But like, I think we all know what the somatic nervous system does, right? It is for voluntary muscle activity. So like in voluntary muscle, like if you have muscle pain, you will not feel it and you have subanesthetic levels of ketamine. Understood. So it doesn't cause you not to move, like it doesn't make you feel like your muscles to be relaxed. It causes analgesia, like less pain. You don't feel pain. Like in the somatic areas, like muscle movement areas. Like if you have pain, like you already had pain, like let me say in your arm. Like if they give you ketamine at sub-anesthetic dosages, like lower dosages, you will not feel that pain. That's what I'm trying to say. So it is also associated with emergency, delirium, hallucination, restlessness, agitation, or unpleasant dreams at times. These are not common in children and in elderly patients. So like the age where people experience it is between 15 to 35 years of age. Like older people and children rarely experience hallucinations, but just screaming. They're less likely to experience. I beg. So delirium/hallucinations are reduced by giving an opioid or butyrophenones or benzodiazepines or physostigmine. Then like it also increases cerebral oxygen consumption, therefore it increases the and I beg no, it increases cerebral metabolic rate. That's what I think and the cerebral blood flow. Like if you have increased oxygen consumption, like if you have increased metabolism, you have increased oxygen consumption. Mm. Did someone say no? Yeah, and then we shall also have there's also like intracranial pressure increases. Yes, people who have like increased intracranial pressure already and increased intraocular pressure. But shall see these things. There is generalized increase in muscle tone, rigidity and purposeless movements. So we also have the cardiovascular effects. It produces central sympathetic stimulation, which increases arterial blood pressure, heart rate, and cardiac output. We have increased pulmonary artery pressure, increased coronary blood flow, increased myocardial oxygen uptake. However, it may cause myocardial depression, like if the sympathetic nervous system is exhausted. You can stimulate when you overstimulate and the system shuts down. You can have myocardial depression. It can also cause increased myocardial sensitivity to epinephrine, of which you guys discussed the effects of epinephrine on the myocardium, right? In the movie. We all know why you need to recap. Okay, let me tell you. Like when you have increased myocardial sensitivity to epinephrine, like because like the effects of epinephrine generally like on the myocardium, contractility and release of renin via the beta-1 receptors in the myocardium. So like remember you already have increased cardiac output, and then like if there is also increased sensitivity to epinephrine, you'll have increased contractility. You get like so the heart rate will increase. So respiratory effects. It preserves laryngeal and pharyngeal airway reflexes. It is a potent bronchodilator. And then ketamine causes increased secretions, but this can be limited by giving anticholinergic drugs. Do we know anticholinergic drugs? For example, atropine, clinidium, not clinidium, that's atropine. You can give atropine to counter that, like that, excessive secretions. Then IV ketamine injection may cause brief transient apnea. Transient anything is when like that's something like you have a state of apnea, then like immediately after you have normal state. You get like if something is transient, like let me say they say transient hypotension. You have hypotension now, then the next like 2 seconds, like your blood pressure is normal. Then you get it. Yeah, that's transient anything. I've explained that. Then in the eye, there is transient increase of intraocular pressure, and eye movements are often persistent during the surgical anesthesia. But you say this like the patient is having, what did we say in the beginning? No, also like can increase intraocular pressures. Yes, it's right. Then, but like remember I said in the beginning that the patient is in that state of, yeah. What's the term? Does anyone remember? Hmm. I said it and I was even forgotten it. Dissociative anesthesia. Like since the patient is in that state, like there will be eye movements, like as the patient is awake, but they are not. So, indications for induction of anesthesia in high-risk patients, like patients, shocked patients, asthmatic patients. Like remember, like if a patient is in shock, you can't give sodium therapy. So, like, but ketamine is safe, you can give. And also in asthmatic patients because it doesn't suppress the respiratory system. To supplement regional or local anesthetic techniques in pediatric anesthesia during minor surgery, used during brief diagnostic procedures because like it will take a longer duration of time than sodium therapy, to like 15 to 30 minutes before it wears off. But then it takes 5 to 10 minutes. I think that's why they said it's slower acting. Julius, are you getting? So it is slow acting because it will take like 15 to 30 minutes before it gets done in the system. Compared to sodium therapy, which is ultra short acting, it will last 5 to 10 minutes. You've understood the difference? So then, in developing countries where anesthetic equipment and trained staff are in short supply, I found this very not funny. So ketamine, like the contraindications of ketamine, airway obstruction or anticipated difficulty in the airway and raised intracranial pressure. Remember when you have raised intracranial pressure and you give it, like if you already have like, because the drug itself causes raised intracranial pressure. I think that's why they say even in the eye, the other one was effects on the eye alone. But remember that the eye is also like, it has nerves leading to the brain. So if you have increased intraocular or intracranial pressure, you give it and it increases, you can cause nerve injury. So contraindications, absolute. But you can give with caution in cardiovascular disease, unsuitable in but it's unsuitable in pre-existing hypertension. Remember we said it will increase effects of epinephrine on the myocardium and also increase heart rate. It will increase the blood pressure you get. So if the patient is already having pre-existing hypertension and you give it, the patient can like end up dying to heart attack. Then ischemic heart disease or severe cardiac decompensation. Cerebrovascular disease. I think they mean like the patient has experienced stroke, right? Or transient ischemia. Then visceral stimulation. It poorly suppresses response to the visceral stimulation. Supplement with an opioid. Then visceral, we know like the visceral organs, the GI. Then history of psychiatric illness because it causes hallucinations and delirium. If the patient already has psychiatric disease and you give like it might, the disease. Then open eye injury because like if you have eye injury, like most likely the person will have increased intraocular pressures. So we are going to propofol. This one is such a good drug. Knocks you out in seconds. Anyway, it's an IV anesthetic or hypnotic. It belongs to the family of alkyl phenols. Propofol is a sweet drug in the OR, but definitely not for use for home use. It is more expensive but very popular because of its favorable recovery characteristics and its antiemetic effects. It is extremely lipid soluble but almost insoluble in water. We said like for a drug to be good, like during its absorption, it is supposed to be lipid soluble. So like it will easily cross the blood-brain barrier because it's highly lipid soluble. And it has a pH of 7, therefore like it's neutral. So I think like it will easily reach in an ionized state in the the drug for any compound, pH of 7 is neutral. But for our blood pH, isn't it from 7.5? 6.5 to 7.5, I think, right? What's the range? For blood, for our blood. Mm. It has a range, but I don't remember which one, but it's in the sevens still. So it will easily reach in non-ionized state in the brain. So they're saying that like the emulsion of propofol consists of 1% propofol, which is 10 milligrams per ml, 10% soybean oil, soybean oil, then 2.25% glycerol, and 1.25 purified egg phosphatide. That's why it appears like milk. It is white anyway. Then does not cause ketamine. I think no, I was going to say it's yellow. Sodium thiopentate is yellow. Ketamine, I don't remember. Ketamine, I don't remember for sure. Ketamine is not milk. For his white when you put it in the drip turns white. So has no effects on muscle relaxants. I say like does not cause histamine release, nor triggers malignant hyperthermia. Like malignant hyperthermia, like for you to know that the patient is having malignant hyperthermia, you're supposed to have symptoms like that include muscle rigidity, high fever, and a fast heart rate. But like most of these drugs, the IV drugs, do not cause malignant hyperthermia. Malignant hyperthermia is common in inhalational anesthetics. Hope you understood. Hmm? Like they're saying, like propofol is good because it does not stimulate, it does not cause histamine release, nor does it trigger malignant hyperthermia. Then I said, most of these IV medications do not cause malignant hyperthermia, but rather the inhalational drugs cause malignant hyperthermia. You get sevoflurane, isoflurane, those ones cause. And they say like for the symptoms of malignant hyperthermia, I say symptoms for you to know that the patient is experiencing malignant hyperthermia. They experience muscle rigidity, a high fever, and a fast heart rate. So heart rate increases. So, and malignant hyperthermia is usually, I said it's common in inhalational anesthesia. Have we understood? So, it has no effects on muscle relaxants and it's associated with a low incidence of nausea and vomiting. And it has a short effective half-life of 30 to 60 minutes. Propofol. Dosages. In healthy and premedicated people, the dosage is 2.5 to 3 milligrams per kg. Pre-medicated people, 1.5 to 2 milligrams per kg. Elderly patients, less than 1 milligram per kg. Children, 3 to 3.5 milligrams per kg. Maintenance of anesthesia, 50 to 150 micrograms per kilogram per minute, combined with nitric oxide and opioids. Then, sedation of patients in the ICU, 35 micrograms per kilogram per minute, plus morphine, 2 milligrams per hour. IV conscious sedation for operative procedures with local anesthesia, 25 to 75 micrograms per kilogram per minute. Effects of propofol on organ systems. CNS, it mainly stimulates the GABA receptor. Did I check? Yeah, it causes CNS depression. It mainly stimulates the GABA receptor. Then IV dose, I think I read it right now, I forgot. The mechanism of action. Okay, let's continue anyway. So, IV dose induced anesthesia occurs within 20 to 40. No, I think seconds, right? Because it's a fast drug. I tried to check, but I didn't write these things and I've forgotten them. Then, cerebral metabolic rate, cerebral blood flow, intracranial pressure are decreased. There is rapid recovery of consciousness and minimal hangover effects. Propofol has an antiemetic, antipyretic, and an anticonvulsant properties. And sometimes may induce convulsions, and it is not recommended for anesthesia in epileptic patients. So like I feel like for you to give this drug, you're supposed to know your patient, like know the patient. Epilepsy, asthma, heart conditions, like respiratory conditions, so that you decide on which drug to use for induction. So cardiovascular, it causes vasodilatation and slight negative ionotropic effects, cause decrease in blood pressure greater than with thiopentol. The degree of hypotension is substantially reduced by slow IV injection. It attenuates pressure response to tracheal intubation better than thiopentol. Heart rate may increase slightly, but occasional reports of severe bradycardia and asystole exist. So, you have someone. Sorry, but anyway, almost finished. Let me just finish. Give glyco, pyronium, or atropine in patients with existing bradycardia. Because I think like atropine will stimulate the system. Then respiratory effects. It will cause respiratory effects after induction, transient apnea. Remember I said transient anything, right? Transient apnea occurs more commonly and longer than if you give thiopentol. Then on the ECG, ventricular tachycardia will decrease and the RR intervals will increase. So I tried to check like the implications of like RR increase and like I failed to get the explanation. Maybe if someone can explain. Yeah, the RR. No, but like remember the interval increase means like it becomes like that the tachycardia decreases, like they're saying VT decreases, ventricular tachycardia. Remember that PQRS is for the ventricles, not the atrium, not the atrium. So like if they're saying ventricular tachycardia decreases and RR intervals will increase, the heart rate, yeah, yeah. Hmm? I don't know why they put it here, but I think like in the end it affects also like respiration. Mm. Actually, no, respiratory rate, not RR, sorry. I don't know. Respiratory rate, sorry. So, but what is VT? Me, like I think that's why I actually ended up in RR. Like when I tried to Google VT, they gave me ventricular tachycardia. So maybe like VT is what? Ventilator something? Because I tried to look for it and they ended up giving me ventricular. That's why I actually like translated RR in respiratory when your heart rate. Sorry. Maybe it's on that ventilatory peak flow meter thing. Like maybe that's where VT is, right? Anyway, like you will all find out, right? Please go and research. Dr. Stella, read about this. Read about this. So respiratory rate will increase. It increases when you give propofol. It causes decreased ventilatory response to carbon dioxide. Therefore, therefore, oh my God, it's just, it will cause like no. It will cause respiratory depression because like our bodies depend on carbon, like the presence of carbon dioxide to actually like enhance breathing. Like if the ventilatory centers in our body are stimulated by presence of carbon dioxide in the body for you like to stimulate breathing. So if you have reduced response to carbon dioxide, that means you'll have respiratory suppression. Mm. So, like with other agents, ventilatory depression is more marked if opioids are administered. Like if you give together with opioids, then you'll have a worse effect. Synergistic effects. It has no effect on the bronchial muscle tone, and laryngospasms are very uncommon. Low incidence of coughing or laryngospasms when the LMA, you say laryngeal mask, is introduced. Drug of choice for LMA, it is the drug of choice for LMAUs. We say it like LMAUs will have like an effect, will cause laryngospasms when we give what with sodium thiopental, right? So, but like with propofol, you can give with the LMA. I think in other countries. When they're intubating, is that intubation thingy? Like this laryngeal mask, which can't even do like when you're intubating, intubation, of course, like you put the thing inside. I thought that's how all laryngeal, like intubation apparatus are. If I thought intubation is when you put something in the airway, because no, intubation is the procedure. Mm. Okay, so what are the effects on the respiratory? Like propofol will cause respiratory depression. Mm-hmm. So for now, mm-hmm. Also like sodium thiopental doesn't cause hallucinations either, so you can give sodium thiopental too. Mm-hmm. So in the skeletal muscle, it causes reduced tone. Sodium thiopental also causes reduced muscle tone. Mm. In the GI, it has no effect on the gastrointestinal motility, low incidence of postoperative nausea and vomiting. and a good day and good for day case surgery. Uterus and placenta has no clinically significant effects on the uterine tone. However, it crosses the placenta. Endocrine. Plasma concentrations of cortisol are decreased after administration of propofol. Because what are the effects of cortisol in the body? I feel like cortisol acts everywhere in the body. It's supposed to for fight flight. So like so for it the balloon is at the bottom because the ones I've seen the balloon is on the side and it's at the bottom. Oh, to pass the endotracheal tube. I've understood. I've understood. So, the effects of propofol on the endocrine system. So far, it's the only drug you've seen that has an effect on the endocrine system. It decreases the levels of cortisol. And remember, cortisol is a hormone for fight and flight. So, yeah, it decreases the plasma concentrations of that drug. Share with the class, please. No, no, they only open bars and casinos. Massage? No, they open gyms, I think. Ask them. So, cardiovascular depression, like the adverse effects of propofol causes cardiovascular depression, likely to cause profound hypertension in hypovolemic or untreated hypertensive patients, or those with cardiac disease. You administer slowly or by infusion. Then it can also cause respiratory depression, like we said, and can lead to transient apnea, common at induction. Excitatory phenomena during induction, occasional convulsions and myoclonus during recovery from anesthesia. Like we said we can't give propofol for who have epilepsy. Then, other side effects, you have pain on injection, and it occurs in up to 40% of patients. You have pain on pain in great pain is greatly reduced if a large vein is used. A small dose of 10 milligrams of lidocaine is injected shortly before propofol, or lidocaine is mixed with propofol in the syringe. 1 ml of 0.5 or 1% lidocaine per 20 ml of propofol. So, adverse effects, you have allergic reactions, occasional skin rashes, occasional anaphylactic reactions. So, indications. Propofol is indicated in induction of anesthesia, like I said, all these IV anesthetic drugs are used for induction. Then sedation during surgery, during regional analgesic techniques like endoscopy. Total intravenous anesthesia, it is the most suitable agent for this. Then we have sedation in the ICU by infusion to sedate adult patients for several days in the ICU. Contraindications and precautions. Absolute contraindications of propofol, we have airway obstruction, non-hypertensive to the drug. Hypertensive. I was wondering whether it is not making sense. sorry, non-hypersensitivity to the drug and to eggs, because like in propofol we add eggs and something phosphatide or whatever. So let me not say whatever. Let me just say there is purified egg phosphatide. Phosphatide something. Purified egg phosphatide. So if the patient has known hypersensitivity to the egg, the drug, and to eggs, we don't give. Should not be used for long-term sedation of children in the ICU because of reported increased mortality. It is safe in patients with porphyria. Remember, we said we don't give it. We don't give it. Which drug in patients with porphyria? Thank you. Thought you had forgotten. Golden things. Yeah. Yeah. Porphyria. Like remember, like when you have hemoglobin, like the hemoglobin molecule is made up of porphyrin rings, right? So, like, but patients who have porphyria have excessive level. Like when hemoglobin is broken down, they don't like easily lose the porphyrin rings, so they end up with porphyria, like exaggerated concentrations of porphyrins. Mm. Okay, but propofol is safe in those patients. Mm. Then precautions you can give with caution in patients as for thiopental, but he didn't even. Yeah, sodium thiopental, like unstable cardiovascular patients, patients with blood pressure. Remember, didn't we say to cause hypotension in patients with undiagnosed hypertension? Mm. No, like you say, like, but hypertension is worse than hypertension. No, but they already said here, yeah, like here in his slides. Let me read for you again what he said. Say if patients have untreated hypertension, you cannot use propofol because it can cause hypovolemic shock in those patients. Like if they are not on good management. So those are the ones. Mhm. Propofol solution possesses no antibacterial properties and they support growth of microorganisms, like because they have eggs and soya beans in the solution. So observe aseptic techniques and discard unused solution. Because if you don't, the patient might actually end up with sepsis because they promote bacterial overgrowth. Then we have our another drug, the last one. Members, be patient, we're almost done. Etomidate. Etomidate is an imidazole. You're listening to me, so etomidate is an imidazole compound. Remember, like imidazole, we all know imidazole is like ketoconazole, manyawa. Like it has its own ring shape, which I didn't draw. It is a clear aqueous solution containing 35% propylene glycol. Ampules contain 20 milligrams, which is an alkaline pH. Yeah, it's an alkaline solution. A rapidly acting general anesthetic agent with a short duration of action, 2 to 3 minutes, due to predominantly due to redistribution. Like remember, like when we were saying in the beginning, how I explained the redistribution of anesthetic drugs, like to reach the brain and then like afterwards to start redistribute highly vascular organs, the kidneys, the liver, then it will move to the less perfused organs. Yeah. So it is rapidly acting and like the short duration of action. Like this one has actually a shorter duration of action compared to the others. Wow, so sodium thiopental, like the duration of action would be 5 to 10 minutes. Hmm? Then, but this one has 2 to 3 minutes. And then ketamine had 30 minutes. Then now our intermediate is 2 to 3 minutes. And then propofol had, anyone? Also write down propofol. Propofol, the duration of action is 30 to 60 minutes. So it can take an hour in the system. Among all these, like it has the longest duration of action. So intermediate, like, yeah, I've explained, duration of action 2 to 3 minutes. Then it produces less cardiovascular depression and less respiratory depression than other agents. Intermediate depresses the synthesis of cortisol by the adrenal gland. Which other drug causes reduced cortisol? Yeah, you keep saying that we've just seen, and then you forget. And impairs the response of, we discussed for us. Oh man, has it been that long? Adrenocorticotropic hormone. So it reduces cortisol in the adrenal gland and therefore impairs the response to adrenocorticotropic hormone. Long-term infusions of the drug in the ICU are associated with increased infection and mortality due to decreased immunity. I think, like, since it affects, Zencots is a steroid, but it's reducing the synthesis of steroid. So, like, how will it decrease immunity? It decreases immunity, that's what they're saying. No, but cortisol, like I would expect that, since like steroids are the ones that usually decrease immunity. Yes, but like, anyway, I think maybe because cortisol is important in metabolism, like this entire pathway is important in metabolism. So maybe there will be fewer synthesis of all those things, like you say, the immunoglobulins and stuff like that. Therefore, maybe to like reduce immunity. Then approximately 76% is bound to protein. Which other drug is protein bound, people? No. Sodium thiopental. She said ketamine. She said ketamine. That's why I'm telling sodium thiopental. Sodium thiopental, because it is bound to which protein? Yes. And that is why it is affected by, yeah, when the patients have which conditions? And and so it is metabolized in the plasma and liver mainly by esterase hydrolysis, and it is excreted in urine. Now we are on intermediate members. I was trying to help you recap sodium, but now we are back. Terminal elimination, half-life is approximately 75 minutes. It induces anesthesia at an average dose of 0.15 to 0.3 milligrams per kg. It should be administered into a large vein to reduce the incidence of pain on injection. So, adverse effects of intermediate. We have, I also didn't. I'm also not understanding duration of action. Like the drug, I is like we should know what half life. I think half life is the duration it spends in the body, but its active moment takes only 2 to 3 minutes. No, it's a short acting. Like let me try and explain. Like when they give it to you, it will work in the brain like per cycle. Per cycle, it will take 2 to 3 minutes when it's active. But like since it is redistributed, sorry, to other organs in the body, it will take that duration in the body to be in the body. Like, but for it to fully be eliminated from the body, it will take 75 minutes before you excrete it. You've understood? Mm, that's what I understood. But the anti like for him is saying terminal elimination half-life. Elimination, it being excreted. Mm. But it will be in the system. I know. That's why I'm saying like let's first search half-life because I feel like half-life is the time something like the whole hour. Hmm, that's true. So they're saying half-life is the duration of action of a drug is known as its half-life. This is the period of time required for the concentration or amount of drug in the body to be reduced by one half. Yeah, they're saying that like understanding the concept of half-life is useful for determining excretion rates as well as a steady state concentrations for any specific drug. Anyway, not 75 hours, minutes. Okay. That's what I understood, but you can write it down and ask the lecturer. Hmm? No, no, it's YouTube. Now, YouTube videos should take like what, how many minutes? You can read about it. Terminal plasma half-life is the time required to divide the plasma concentration by 2 after reaching pseudo-equilibrium, and not the time required to eliminate half the administered drug. So what I've understood from terminal elimination half-life is that is the time. Like, remember, our drug is protein bound. Yeah. I beg you asked. I am explaining, but you're not paying attention. They're saying like terminal plasma half-life, but I think like that's the time required for the drug to reach plasma concentration of that drug by 2, not the time, and not the time required to eliminate half the drug. I don't know, they're bringing like something different from what I asked. I see. Hmm? Yeah, it's basically time take, like what they're saying, like elimination half-life is time required to eliminate half the amount of the drug in the body, not the time it takes to work. Half-life is the time it takes to work. Elimination half-life is the time it takes to be eliminated. Mm. Mhm. It induces anesthesia at an average dose of 0.15 to 0.3 milligrams per kg. There are few. Should be administered into a large vein to reduce the incidence of pain on injection time, because the things are hard. Adverse effects. We have suppression of cortisol synthesis, that one we saw already, right? Then excitatory phenomena. Which other drug did we say has excitatory phenomena? Was it? No. Excitatory phenomena. I don't remember sodium thiamine having excitatory phenomena. It could be. May become Dr. Isaac. Could be. No, we said excitatory phenomena. Like the way I understand, like I said, cough and hiccups. Did I say cough and hiccups in case you explain it, I said somatic analgesia. So a patient will not feel pain. I said this thing. I think it's either propofol or sodium thiopent, but not. I think it's sodium type. I think you're right. I think it's sodium thiopent. Mm-hmm. And we shall see, but like I think it's sodium thiopent. And your cough and hiccups. Yeah, I think it's sodium thiopent. Someone else has joined. No, you're almost done. No. So, yeah. I put the that they did. Okay. So yeah, we're going to post the video like you guys, let's first finish. We are making it. So excitatory phenomena, like it will have excitatory phenomena where we have moderate or severe involuntary movements in up to 40% of patients during induction, pre-medication with an opioid, decreases the movements. Like the excitatory phenomena, we have cough and hiccups in up to 10% of patients. Then pain on injection, this is experienced in up to 80% of patients if a small vein is used, and less than 10% if a large vein is used, e.g. the antecubital fossa. Then prior injection of lidocaine 10 milligrams decreases the incidence. I think by asking things in the chat. Hmm. So then, like other adverse side effects, we have nausea and vomiting. I think the only drug we've so far said that doesn't cause nausea and vomiting was propofol. And the incidence of approximately 30%, like of nausea and vomiting due to intermediate, is usually approximately 30% and is very much higher than with propofol. Emergency phenomena, the incidence of severe restlessness and delirium during recovery is greater than with barbiturates or propofol. Then we have venous thrombosis, and I think we saw venous thrombosis in sodium thiopental. Sodium thiopental. Then indications and contraindications of intermediate. Indications we have generally has a good use in patients with compromised cardiovascular system, e.g. induction during non-cardiac surgery for patients with mitral valve prolapse or aortic stenosis, also hypovolemic patients. It is suitable for outpatient anesthesia but has superseded, right? Has been superseded by propofol. Absolute contraindications where we have airway obstruction, porphyria, adrenal insufficiency, and long-term infusion, like in the ICU. Porphyria similar to sodium thiopental, then adrenal insufficiency because like there are already decreased levels of cortisol in the body, right? No, because it causes decreased levels of cortisol, and if you already have adrenal insufficiency, you need enough cortisol. Yes. Thank you very much for listening to me. I hope you benefited and have a nice day. I don't know. Any questions, people? But anyway, it's just you and Lou, shall send for you the recording. I think that the video was recording in case you need it.
Thank you.
Yes?
I would need it because I took longer than expected.
Yeah, we shall send for you.
And I only came back now.
It's okay, we shall send for you.
Do.
Is it okay?
Okay.
Okay.
Yeah, it's fine. Thank you.
You're welcome.
When is the next discussion?
When is the next discussion? Tomorrow, right? At 9. Tomorrow at 9.
Yeah, I had requested yesterday to have topics for ophthalmology, like somebody
Pardon?
with all the topics for ophthalmology.
Lou, pardon?
Anyone with all the topics of ophthalmology?
You have the topics of ophthalmology.